It's my pleasure to welcome Professor Annice Mukherjee, who's a consultant endocrinologist, a member of the British Menopausal Society Medical Advisory Council and founder of the Society of Endocrinology Women's Health Summit, and acts as an advisor to Diabetes UK, a menopause work stream. Annice was named by Financial Times in their list of FD Women of 2022, and is actually author of the best-selling book, The Complete Guide to Menopause. So who better than Professor Mukherjee to talk about practical prescribing of menopausal hormonotherapy? Annice, over to you.
Thank you very much, Amir, and thank you for inviting me to give this talk. That's my disclosure. So this is going to be a very practical overview of menopause hormone therapy. It's going to be a whistle-stop tour because I've been given instructions that you really want to know the nitty-gritty about prescribing. So I'll talk all about that, and I'll touch on genitourinary symptoms of menopause and vaginal treatments because I think that's highly relevant as well, and testosterone. I'm not going to talk about POI because new guidance is coming out, and I'm sure you'll have talks about that later in the year when the new guidance is released. So systemic MHT is the first line treatment for menopause symptoms. Sounds very simple, but systemic MHT is not one universal treatment, and the problem at the moment is midlife women with bucket lists of multiple symptoms being told that all their symptoms are likely to be menopause and that MHT will solve them, and it's just not quite that straightforward. So let me go into this in more detail. What we're trying to do is treat the changes in estrogen that are associated with the menopause transition. It can fluctuate in the early stage. In perimenopause, it can drop very low very rapidly in the early postmenopause. So we want to treat systemic symptoms with systemic estrogen, and for that we use oral estrogen in the form of tablets or transdermal estrogen in the form of patches, gels or sprays. And I'm going to go into different formulations in subsequent slides. But because estrogen results in endometrial thickening, potentially hyperplasia and cancer, we must use progestogen in women with an intact uterus to protect the endometrium. And that can be through oral progestogens, an intrauterine system containing a progestogen, or it can be used in combinations, including oral estrogen progestin combinations and transdermal ones. For women in the perimenopause, so that's women who are still menstruating, or at least have been during the last 12 months, we need to use a sequential progestin that we give ideally in the luteal phase of each cycle, which will result in a regular bleed, but will also stop dysfunctional or erratic bleeding. For women who are more than 12 months beyond their last menstrual natural period, we would generally use continuous combined, so estrogen continuously and a low dose progestogen continuously as well. Obviously, women who've had a hysterectomy, a total hysterectomy, will not need the progestogens, so they can have systemic estrogen alone, but there are exceptions. Women who've had surgery for severe endometriosis may have residual tissue, and they will often need to be given some progestogen, particularly in the early phase after surgery. And women who've had a subtotal hysterectomy will need or may need some progestogen, and that's a discussion with the gynecologist. So essentially, treatments need to be tailored to individual needs. So let me talk a little bit more about systemic estrogen. I always get asked, what dose should we start? What sort of doses should we be using? And the little table at the top is taken from the British Menopausal Society tool for clinicians, which talks about doses of different preparations of estrogen. And I would generally start low to medium dose. I would note that the BMS mentions high dose oral, which is 3 to 4 milligrams, which is a beyond licensed dose. So in the section I'm talking about, I'd rather stick with licensed doses, which most of us should be sticking to. So I'd start on a middle range dose, a mild to moderate dose. It would depend on the age of the woman, her symptoms, how likely it is I think she's going to get side effects. But if you start on a low dose and she doesn't get side effects, then you can titrate upwards over the next 2 to 3 months when that woman has more confidence and work out the dose that works for her, minimizing side effects, optimizing symptom control. So oral estrogen doses range from 0.5 milligrams to 2 milligrams. The 0.5 is only in combined preparations, and I'm going to name those in the next slide. And the 1 and 2 milligrams can also be in standalone preparations as well as combined. Transdermally, and needless to say, most of the estrogen we give is body identical. I think the only exception that is currently prescribed reasonably often, I think, is Duaviv. But I mean, I haven't had the necessity to use that because there are so many ifs and buts around that treatment. But usually it's bioidentical estrogen, but with different progestogens, which I'll go into. So the transdermal patches come in several different preparations, and actually the estrogen only patches can be cut to the size that the woman needs. Mostly are twice weekly patches. There is one weekly patch, which is the Fem7 patches. There's 2 gels that are widely available on the market: Sandrina, which comes in sachets, 0.5 and 1 milligram, and Estrogel, which comes in a pump, an easy to use pump, and the woman can pump the number of pumps she needs, lower range 1, higher range 4. And the most recent introduced transdermal preparation is Lenzetto spray, which is generally a gentler preparation. And it comes in 1 to 3 sprays. And as you can see here, even the 3 sprays is only a medium dose. So that might be good for somebody who perhaps might have more side effects or maybe more risks. And the general preparation we use is patient choice. So transdermal is the preferred preparation if you think that there's malabsorption, or if the patient may have other comorbidities, and particularly if there is a risk of VTE or stroke, because oral estrogen increases risk of VTE and stroke, whereas transdermal estrogen does not. So that's a matter of choice. I'm not going to really talk about implants. These are sometimes used by gynecologists after a hysterectomy, generally used for women with really severe refractory estrogen deficiency symptoms, but there's all sorts of problems with implants and tachyphylaxis, so I won't really go into that in any more detail. So let me just talk about the sequential MHT regimen. So if you've got a woman who's got a womb and is still menstruating or has done in the last 12 months, there are different combinations available. So the fixed combinations, and this isn't an exhaustive list, but this is the commonly used preparations. We've got oral preparations, which include Femiston in the cyclical formulations, and then transdermal Everel Sequi, which is a twice weekly preparation, Fem7 Sequi, a once weekly. Femiston contains dydrogesterone, Everel norethisterone, and Fem7 is levonorgestrel. But you can also use 2 separate preparations. So you can use your continuous estrogen of your choice, which I've already referred to. And then with the sequential regimens, you can use a cyclical luteal phase progestogen. So that will be 12 to 14 days per month, and you'd expect to get a withdrawal bleed on completing the progestogen part of the treatment. So micronized progesterone is the body identical progesterone, which has now been available for a few years, and that would be at 200 milligram oral dose. But there's been shortages of that because so much interest in MHT at the moment, particularly in the UK. So alternatives include Provera for 12 to 14 days a month, 10 milligrams, norethisterone 5 milligrams for those women with a BMI under 30, dydrogesterone if it's available. It's not unfortunately available in the UK, but it is available in some countries. And the Mirena IUS can be used for endometrial protection for up to 5 years at any stage in the menopause transition. I would note specifically that 3-monthly withdrawal regimens with just a progesterone course every 3 months have been popular in the past. They're not favoured now because there's a real concern that they don't give adequate endometrial protection, particularly in women in natural menopause as opposed to POI. And higher doses of estrogen that are sometimes being given for various reasons above licensed dosing should be given higher doses of progestogen to cover that estrogen's effect on the endometrium. And there's concerns over this, which I'll go into later in the talk, but the British Menopause Society produced a guidance in 2023 about this because of concerns about underdosing with progestogens. So let me go to continuous combined MHT. So that's for women who have are either at least 12 months from their last menstrual period, or approximately the age of 54, or if they've been on sequential HRT for 5 years, the recommendation is to switch to continuous combined because sequential MHT over a longer period of time can result in endometrial hyperplasia. And with the continuous combined regimens, because the endogenous estrogen production is now low because the woman's postmenopausal, you get an atrophic endometrium and hopefully no bleeding at all. So these combinations are daily estrogen with daily low dose progesterone continuously. So it's all the same all the month. You're not splitting the month. And so the regimens include the Femiston preparations, LS, NovoFem. Bijuve is a relatively newer preparation, which is oral, which is 100 milligrams of micronized progesterone, utrogestan, with 1 milligram of estradiol. Then we've got Everel Conti, which contains estrogen 50 micrograms in a fixed dose with norethisterone continuously, and Fem7, which contains 50 micrograms of estrogen with levonorgestrel. And you can also just use estrogen orally or patches separately from the progestogen and give the progestogen separately. And the doses you'll see are slightly different to what we would see in a cyclical regimen. Roughly half the doses are required. So micronized progesterone 100, Provera 2.5 to 5. Norethisterone, the lowest dose we've got is 5 milligrams, but women only need 0.5 to 1 milligram continuously. Again, dydrogesterone is not available in the UK. And again, Mirena IUS, and I have no commercial interest in Mirena, but Mirena can be used at any stage in the menopause transition for adequate endometrial protection to cover HRT. So let's talk about choice of progestogen. And I've talked about Mirena already. Mirena is a great choice for younger perimenopausal women because it provides contraception. And of course, in the perimenopause, women can have some residual fertility and it can be unpredictable. And it gives endometrial protection for up to 5 years when MHT with estrogen is used. And I think it's fairly obvious from what I've said already, but just to state this, progestogens have anti-proliferative and secretory effects on the endometrium. But when we give progestogens with estrogen, they do impact on breast cancer and vascular risk. And when we're looking at the choice of progestogens used, it's quite clear from the data we have that oral micronized progesterone, which is the body identical progesterone, the only one that's available, and dydrogesterone, which is its stereoisomer, are the safest progestogens in terms of vascular and breast cancer risk. And that was shown in the Lancet meta-analysis that was published in 2019. And micronized progesterone is also neutral to VTE risk. So, you know, you would think for women with multimorbidity, this would be a really great option, reducing their vascular, breast cancer and VTE risk. But there's another flip side to that, which I've already alluded to, which is that sequential MHT, giving the progestogen for part of the month, whilst it has a more favourable effect on breast cancer risk, it has a less favourable effect on endometrial protection than continuous combined MHT and vice versa. And cyclical micronized progesterone may not provide adequate endometrial protection in some at-risk women. Now, I'm going to go into more detail because I'm being a little bit non-specific there. So let's talk about this. It's the unmentionable. In the UK over the last couple of years, since the recent upsurge in MHT use with the sort of celebrity media and social media awareness campaigns, we've seen an absolutely dramatic rise in heavy menstrual bleeding on MHT. To the point where gynecology 2-week wait referrals have risen by 150% in the UK, which is crippling gynecological 2-week wait services. And this is a big concern, and there's going to be some new guidance about this coming out later this year. Now, linked with that, we know that endometrial cancer incidence and mortality is rising significantly, and this is tightly linked with the worldwide obesity epidemic. And we know that obesity is an independent risk factor for endometrial cancer. And my colleagues in Manchester, Emma Crosby's group, have published widely on this. They did a nice review article in The Lancet in 2022, demonstrating the concerns about this. And so the big concern is the use of cyclical micronized progesterone in younger perimenopausal women, perhaps who have comorbidities. There are concerns because the French E3N cohort study has shown that cyclical micronized progesterone in doses that are currently licensed for combined MHT may not be sufficient to prevent estrogen-induced endometrial hyperplasia in cancer. And this just emphasizes that an individualized approach to management and choice of hormone treatments is really important when prescribing menopause hormone therapy. And multimorbidity, like with everything to do with multimorbidity, really needs careful consideration. So let's move on from that and let's talk about Tibolone, which I'm sure you've all seen and possibly prescribed. So Tibolone is quite unique. It is a gonadamimetic and it contains synthetic estrogenic, progestogenic and androgenic components. It's an easy single dosing schedule, a tablet 2.5 milligrams taken every day. And because it's similar to a continuous combined HRT with the same hormones all the way through the cycle, it's only suitable for postmenopausal women. So the USP of Tibolone is that it can improve mood and libido, particularly through its androgenic effects. And it doesn't increase VTE risk, even though it contains oral estrogenic components. And of interest in women who've no history of breast cancer, it has a lower risk of primary breast cancer. So for certain women, perhaps younger postmenopausal women who might have a VTE risk, but no other significant risks, it might be suitable. But there's always a but with everything. Tibolone has a 2.2 times higher risk of ischemic stroke, which was demonstrated in the LIFT study published in the New England Journal of Medicine a few years ago. So if you've got an older woman, perhaps with multimorbidity, who has hypertension or other risk factors for stroke, then it wouldn't be a good choice. So I'm now going to go into managing side effects with hormone therapy. So again, the table at the top is a table from the British Menopause Society, and it emphasises that side effects can be related to estrogen. They can also be related to the progestogens. There are many, many side effects, I'm afraid, and we all want women to just go on HRT and be fine, and it just generally isn't as straightforward as that. In fact, many women will get mild transient side effects, and generally if the side effects are mild, I tend to reassure them and tell them that they're going to settle down. Particularly PV bleeding is very common, and if it's mild or minimal, I reassure women and tell them it will settle, as you know, it should settle within a few weeks or months. But if there are any red flag features like pelvic pain or severe or chronic bleeding, those women will have to be referred on a 2-week wait pathway or sent to a gynecologist at least. Breast discomfort is really common and usually settles. Evening primrose usually sorts it out. And as stated in the BMS guidance, reducing the dose, adjusting the doses, changing the product, changing the delivery route is something that often is needed in the first few months to get the dose right. And for most women, we can get there within a few months. But for some women, every single preparation is not tolerated or causes problems. Some women just cannot tolerate MHT. And I think that's, again, a narrative that isn't being amplified in the media, but it's a reality. So other practical points. We need to review the patients when we start them on MHT for all the reasons I've explained. It can take a little bit of time tweaking the medications to get the treatment right and until these side effects have resolved. But thereafter, once they're stable, a yearly review is fine. And if the patient doesn't have complex health issues, then primary care follow-up can be undertaken until there's any change in need. I always get asked about measuring estrogen. It's not routinely needed in the context of the natural menopause transition. We dose titrate dose to symptoms, basically. So it's really the symptoms that are telling you what to do and the side effects, not the estrogen level. In fact, estrogen level can tie people in knots, and I'm seeing that a lot at the moment in primary care. Occasionally, estrogen levels are needed. They can be helpful in patients who are treatment refractory, just to tell whether the symptoms are related to persistently low estrogen levels. And they can be helpful if you've got a woman who's got recurrent low trauma fracture or osteoporosis, where you really do want to make sure that they've got good estrogen levels. So how long do we use MHT for? So remember, we're using MHT for symptoms. The risks and benefits for each individual woman and side effects will differ both between women and within an individual woman, those risks and benefits and side effects can change over time. So whilst treatment is not time limited, and actually while a woman is really finding she's benefiting from MHT, we shouldn't be forcing any woman to stop. But on the other hand, most women's symptoms do settle down over time and they can tail off treatment without significant residual symptoms. Women should be discouraged from aiming to use MHT with the sole aim of, or main aim of, disease prevention. That is a prevailing narrative of misinformation that we're seeing in the UK. The evidence is completely absent that all comers will benefit from MHT, except perhaps in very selected women with osteoporosis, recurrent low trauma fractures who have no comorbidities and very low risks associated with MHT. And that's not the majority of women in the longer term. Now, the United States Preventative Services Task Force, which is a very, very esteemed organisation, did a huge review of all the data in 2022 and published in JAMA, and reiterated that MHT should not be used for disease prevention, neither combined nor estrogen only MHT. And that is the position of all the impartial international menopause societies as well. So I'm going to talk a little bit about genitourinary symptoms. It's very, very common and it's not talked about. It's increasingly talked about now on social media, but that's a recent thing. About 50% of postmenopausal women will experience genitourinary symptoms, and actually up to a third of women who are treated with systemic MHT will experience them. The symptoms can be diverse, from dryness, itching, pain, discomfort, and recurrent urinary tract infections. Now, low-dose vaginal estrogen is a really effective treatment for the vast majority of women with these symptoms and is recommended in the NICE guidelines, which absolutely are reassuring regarding the fact that there is minimal systemic absorption, there are very few or minimal side effects, and no progestogen is required to protect the endometrium with low-dose vaginal estrogen. I've written some of the options here, but really, I mean, there are a few. You can use a pessary, a cream, or a ring. It's patient choice, really, and there's not really an end time, but some women will choose to have courses of these treatments and some women will want to have them long term. There are other treatments for women in whom vaginal estrogen isn't helpful or it's not preferred. There is vaginal DHEA, Progesterone, which is also a gonadomimetic, which is also used as a pessary daily, and that suits some women very well and not others. And then oral ospemifene, 60 milligrams daily, is a SERM. It has a role, but it has a risk of endometrial hyperplasia and venous thromboembolism, so it has to be very selected cases, really. And I think going back to vaginal estrogen, this is something that we always talk about these days, is that a year's worth of licensed doses of vaginal estrogen is the equivalent exposure to that woman systemically of one dose of 1 milligram of oral estradiol. So that's 1 day of systemic HRT in a year's worth of vaginal estrogen. It's very helpful for many women. So a few words on testosterone. So we've still got the NICE guidelines from 2015 and 2019 review. We will have new NICE guidelines coming out this year. But the recommendations are that any woman who you're considering giving testosterone to should ideally be adequately estrogenized prior to considering testosterone. And you also need to exclude physical health and psychosexual health factors that could be impacting on libido. And they should really be addressed before starting testosterone, because otherwise testosterone simply won't be helpful. And again, at the moment, many women are rushing to go on testosterone and then finding it's actually not helping because they haven't addressed other significant issues. It's recommended that testosterone levels are checked prior to treatment. That's logical. I mean, if they've got a high testosterone, you're not going to start them on treatment because you don't want to push the testosterone higher. And then check the level once the treatment's stable at 3 to 6 months to make sure you're not over replacing them. And also obviously monitor the clinical response. Androfem is a licensed preparation from Australia, but it's not available on the NHS. It's prohibitively expensive. And so the British Menopause Society actually supports the off-label prescription of testosterone gels that are licensed for men. The two preparations that are the easiest for women are Tostran, which unfortunately is currently unavailable, and Testogel Pump Pack, which is a double dose of Tostran. So we tend to recommend the Testogel in a pump, half a pump twice a week to start with, and then up or down titrate to symptoms. The benefits of testosterone when used appropriately for women in the menopause transition are significant and have been demonstrated. The biggest body of work on this is Susan Davis from Melbourne, Australia. You can look at her work. And she's also done all the placebo-controlled trials. And one thing that has been clear from her work is that all the well-being benefits, the joie de vivre, the getting your mojo back, which is again being touted with testosterone at the moment, those well-being benefits are no more than a placebo effect. They are completely neutralized when you look at placebo-controlled trials. So we should be using it specifically for libido. So just to finish really about MHT contraindications. A personal history of breast cancer or other estrogen-driven cancer is considered a serious contraindication by all the impartial international menopause societies. There are exceptions to every rule, but in general, it isn't safe for those women. It's going to risk their cancer returning. And so really, it needs to be a really counselling discussion with women. But unfortunately, a lot of women who have had estrogen-driven cancers at the moment have got big time fear of missing out because they think MHT is such a miracle cure, and this is a problem for the breast oncologists at the moment. Now, all other contraindications are generally relative. So things like venous thromboembolism and even cardiovascular disease, oral estrogen is a risk and should be contraindicated in those settings, but transdermal estrogen with oral micronized progesterone does not appear to increase risks. So for most other considered risks, the contraindications are only relative. And remember, I talked about women who can't tolerate MHT and all these women who are told they can't have it because of their contraindications. There are alternative systemic treatments depending on what the symptoms are. And there are also vaginal estrogen is safe for the majority of women, even quite a few women who've had estrogen-driven cancers. But if they have had an estrogen-driven cancer, it should always be a discussion with the cancer team. So I'll summarise. I hope I haven't overrun and have a bit of time for questions. MHT is currently the first-line medication to treat menopause symptoms, and that's still the same in the current NICE guidelines, although we are expecting new guidelines coming out. We need to select formulations to maximise individual benefits and minimise individual risks. Personalisation of care has never been any more important than it is in menopause care. Risks and benefits with MHT are very low in most healthy women going through the menopause transition, but risks and benefits change over time, and rising rates of chronic disease and multimorbidity mean that risks with longer term treatment may be higher and efficacy lower for some modern cohorts of women. And I think it's important for you all to be aware, wherever you're based, that expectations of MHT by women at the moment may be unrealistic because of media and social media misinformation, which is across the globe. Okay, so I'll probably finish there.
Move on to our final speaker of the Reproductive Endocrinology Masterclass, Dr. Channa Jayasena, who's a consultant in reproductive endocrinology and head of andrology services at Imperial. And he's an internationally recognized clinician scientist who's interested in the metabolic regulation of male fertility and testosterone secretion. And indeed, Channa co-chaired the 2021 Society of Endocrinology guidelines for testosterone treatment in men. So it's a real pleasure to have him to talk about some of the recently published data, which may change the way we look at the safety of testosterone treatment in men with low testosterone. Thank you. Channa, over to you.
Thank you, Professor Sam, for that very kind introduction. Just confirming, yes, I think the screen is shared. So I'm going to try to give a very focused update on some really exciting data, which hopefully brings forward this question about the safety of testosterone in men. So how safe is testosterone? And I think this is best answered in two ways. We don't see clinical trials, randomized controlled trials of young men who have lost a testis or with hypoc, because those trials are unethical. It is assumed that it's completely safe, and because you're replacing physiology, and the treatment effect is large. People will go through puberty and develop facial hair for the first time. What we're really talking about when we call safety, is this problem here, is that increasingly there's this shift towards prescribing such that the average person worldwide in many countries, including our own, I think, is often middle-aged, older, may have comorbidities. And for this reason, there are concerns about cardiovascular safety because they're not young men, and often there are potentially reversible causes for their problems, such as obesity and diabetes as well. So in terms of sort of background context, worldwide prescriptions have been increasing mainly in men between the age of 40 and 59. And the effects potentially of testosterone, if we look from a basic sciences point of view, it does actually have coronary vasodilatory effects, which could be good, but unfortunately it also increases muscle mass and therefore insulin sensitivity, which sounds good, but it does actually increase and stimulate erythrocytosis, which you'll know, which could therefore increase thrombotic risks. And a minority of studies reported increased cardiovascular risk, which led to a US FDA safety advisory, which is still in place. So this has cascaded and filtered through to cause great uncertainty in prescribing, because the guidelines are uncertain, and everyone has said we don't know how safe testosterone is in these men. So I was very fortunate to lead and asked to assemble a research team and a consortium to try to address objectively questions. And this was funded by the NIHR. And what we did was that we did qualitative economic evaluations, but what I'm going to concentrate on is part of our individual patient data meta-analysis, which involved over 3,000 men involved in randomized controlled trials from all around the world. I just want to pay tribute to the fact that this was very much a team effort involving many researchers who actually donated under embargo their source original data so that we could try to make inferences that hadn't been possible before about the safety of testosterone. Just to explain what the difference between an IPD meta-analysis and another meta-analysis is, the key thing is that you are able, because you're not just reading data from the paper, you independently corroborate and adjudicate on data quality. You look at their actual databases. We actually rescored independently and blinded adverse events. We recategorize them all. And we can look and we can do sensitivity analysis. So we could actually gate and exclude things. We could reanalyze all our outcomes according to smokers or non-smokers, diabetics or non-diabetics, older men, etc. So we were able to really do some powerful sub analyses. In terms of the remit of the inclusion, we included RCTs that use testosterone treatment and which use placebo as a comparator. We included men aged over 18, and we decided to be quite broad with our definition of low testosterone. So a testosterone less than 12 was considered in remit. But of course, one of the key things we did was then actually say, what about men with a testosterone below 8 or below 10? So we kept it broad so that then we could do comparisons. We included crossover designs, very short trials because we thought those would not be suitable for looking at safety, and combined interventions if testosterone was given with another hormone, and studies in conditions like HIV, for example, where we thought that would really affect safety data, and studies restricted to syndromic causes such as congenital hypoc. So as I said, we basically spent 2 years going around the globe asking and negotiating very carefully with researchers if we could have access to their data, and we were successful in getting just over half of about 60% of the data. The studies ranged from 3 months to 36 months, and the average trial duration was 9.5 months. This is really important. The average participant who took part had a BMI of 30. Many of them had diabetes. They're in their 60s, and a lot of them had been smokers. Angina was very common. So this was a really, I thought, really relevant population in which to study the safety of cardiac events. I think it's also important to say a limitation, which is because everyone was so nervous about the cardiovascular safety of testosterone, you know, none of them had been powered or designed to look at this as an endpoint. So what we were doing was trying to see what was there a participant who'd had a stroke, was there a participant who'd had something, but none of these had actually been designed to look for these things. So the most important, well, one of the most important things is actually looking at, mortality. I've just put in blue the highlights, which is that there were out of 1,600 people who got testosterone, 6 deaths, and in a placebo group there were 12 deaths. So there was no significant difference. And all we can really comment on is that there were few deaths in men receiving testosterone. What about cardiovascular and cerebrovascular events? So if you look at the top line, there were a total of 120 events that we, in a blinded way, looked at individual patients and looked at their report on their database and adjudicated whether they'd had an event and what they'd had. And actually, there was no difference between the testosterone and placebo arm. If we break it down into cardiovascular events, it was very similar. And again, there was no significant difference in cerebrovascular events, very small numbers indeed. So this there's a wealth of data that we're looking at, and just to simplify it, anything in green means that it went up in the testosterone arm, and anything in red means it was lower in the testosterone arm, and anything black didn't change. So as one would expect, when you're giving testosterone, you would clearly increase levels of testosterone and free testosterone. There was slight look at lipids. There were slight reductions in total cholesterol, but also HDL and also triglycerides. So very subtle changes, both good and bad, perhaps, in lipids, although so small that it's difficult to infer what that would mean clinically. As one would expect, hematocrit went up, and there was a reduction in glucose, although not in HbA1c. But remember, testosterone puts up your hemoglobin, so actually, even if it did reduce HbA1c, you probably wouldn't see it because the HB is going up. And there was no effect on blood pressure as well, compared with placebo. These were not primary outcomes, but we were interested in seeing if there were any other relevant outcomes. So diabetes complications were very similar. So diagnosis of prostate cancer, there were no significant differences, although there were very, very small numbers. Edema was more common, and that has previously been reported as a consequence of testosterone administration. And one would expect, I'll be suspicious I didn't see it, but high hematocrit is a feature of testosterone as well. Very small numbers of other adverse events. So on the basis of our data, we managed to get individual patient data from the majority of clinical trials done to date of testosterone monotherapy. And what we found was that there was no unifying, there was no increase in cardiac events. However, one limitation is that there were very few deaths, and also everyone was using different definitions of what was a cardiovascular event. So we did our best in a blinded manner, objectively, to classify everything. And also one could argue that 9.5 months is not a very long time to develop things like atherosclerosis. And finally, of course, we didn't get, one could, play devil's advocate and say, well, you didn't get all the data, did you? Maybe the ones who didn't provide data were the worst. So we did also what we call a 2-stage meta-analysis, where we compared our IPD meta-analysis with the overall aggregate traditional meta-analysis to look for discrepancies, and we didn't see any. So there was concordance, which makes us less suspicious that there was selection bias. So in terms of key findings, we can say few deaths have actually occurred during trials of testosterone. I think that's really important because we have disclosure that there isn't some massive cohort of men who've keeled over and died that haven't been reported. Few deaths have occurred. There's no current evidence, certainly at the time we published our study, that testosterone changes cardiovascular risk within the first year. And actually, I haven't presented this, but just to say, regardless of age or smoking status or diabetes status or the starting testosterone, there was no high risk group identified. So these were unifying results, and there was no effects on glycemia or blood pressure, and actually previously reported effects on hematocrit, edema, and reduction in HDL. And what we said was that the long-term safety requires further investigation. Funny, and we happen to know that this massive trial that was mandated by the Food and Drugs Administration in the United States was going on and had been going on during the pandemic. And so this was released to much fanfare in July. So I'm just going to summarize the results. So because of the FDA ruling, they made the drug companies in the United States fund an enormous study, by far the largest testosterone trial ever, with over 4,000 men. And this was powered for the first time to cardiovascular safety. So a monumental study. So they took men with established cardiovascular disease at high cardiovascular risk with in their unit, 300 nanograms per deciliter, so which comes out to about 10 nanomoles per liter, and at least one hypogonadal symptom. So and they excluded men with very severe hypogonadism, where it's unethical to randomize them to placebo. People who'd had some sort of coronary or cardiac event within 4 months. People who'd had testosterone recently or had, uncontrolled heart failure, prostate cancer, or thrombophilia, which would make it very risky to put them in a trial. And they aim to get over 5,000 men. Actually, I don't think they quite made that. I think they got to 4,000 something. And men had varying follow-ups, but the mean follow-up was nearly 3 years. And the mean treatment duration was just under 2 years. And actually, during the study at baseline, these men had reasonably low serum testosterone levels. And look at the risk profile. So very similar to our cohort. So 63, average BMI 35. Half of them had established cardiovascular disease, 70% diabetes. They all had hypertension. They all had horrible lipids. 20% were smokers, 15% had stage 3 CKD. So this is really, really high stakes stuff. So if any trial was going to answer the safety of testosterone, this certainly was. And this actually is a really nice starter for results. We're showing on the x-axis months since randomization. So there was a really big kind of attrition. So not many people actually made it to 4 years. But most people made it to about 2 years. And what this shows is that in the blue, that's people receiving placebo, so that's their endogenous testosterone. And what you can see is the testosterone levels in those treated is shown in the sort of the gold bars. And there's a slight drift down, as you might expect, because people may have been waning in their compliance. But it does show overall that most of them would have been taking them, albeit to varying levels. And the primary outcome here was MACE. This is a cardiology term, and there's a specific definition. It means major adverse cardiac event. And the most common definition is basically dying of a cardiac event, non-fatal MI or non-fatal stroke. So these are all bad. And the trial was powered to stop once 256 MACE events happened. And here are the results. So we're looking at on the x-axis the number, the time in months since randomization, And can you see only 70 people made it to 4 years? So I think it's a bit unfair to actually to look down that far. So let's look like halfway up. So many people made it to 24 or 30 months. And we're looking at the percentage of men on the y-axis who got a MACE event. And the blue is placebo, the gold is testosterone, and they are identical. So what this says is that there is no increase in MACE risk, at least up to 2 years. And then they broke it down to cardiovascular deaths on the left, non-fatal stroke and non-fatal MI. And again, there are no significant differences between any of these outcomes. So there's no increased risk of testosterone in men with, let's face it, very high levels of risk in any of these. None of these were significantly different. And they looked at some other outcomes as well. So they looked at pulmonary emboli, DVTs, and prostate cancer. And again, none of these were discrepant between the groups. So in limitations, and this there was quite a bit of criticism as well. One thing that people said was that, you know, if you're giving these men testosterone, why did so many of them drop out? You know, because you'd be a bit worried, because if they were getting so much benefit, well, they should be motivated to stay on. And the researchers said, well, it was the pandemic, etc., etc. So that's an interesting one. It's not the topic of my talk, but actually how much benefit is testosterone. The other thing is, this is limited to 2 years, you know, looking at the amount of data, so we can't infer anything beyond that. So just to really finish, how safe is testosterone? Please, in young men, there must be no doubt and no sort of confusion. It is safe. You are replacing what is missing, and there can never be clinical trials because that would be unethical. There is no concern. But in middle-aged or older men, then we now know for the first time there is no cardiovascular risk from Traverse within the first 2 years of administration. So putting all of this together, the testes and Traverse, there is no evidence that testosterone elevates cardio or cerebrovascular risk within the first 2 years. There are no high-risk groups that are identified, and I suspect that the US FDA will actually change their safety warnings. There are no effects on glycemia or blood pressure. There are effects on edema, hematocrit, and HDL, which are HDL effects are tiny, and prostate cancer risk. Actually, this needs to be updated. So, you know, they have just submitted the Traverse group something showing that they have failed to show increased prostate cancer risk formally as well. So that's another one off the list as well. So I just want to acknowledge for all the contributing trialists who took part in testes, the patients, and the study advisory group. Thank you.
Thank you so much, Channa. That was absolutely wonderful. We are running out of time. There are a couple of questions in the, I might just pick a couple from here. So definition of middle-aged.
Yeah, sorry, that was a lazy term. So I mean, what I would say is, what to be precise, I think when men are above the age of 40 and therefore more at risk of sort of diabetes and obesity and ill health, then I think you're more at risk of that ill health causing what we call functional hypogonadism, low testosterone. So I think to essential purposes, it's greater than 40.
And increased risk of fractures. Any comments on the recent trials? Absolutely.
So I didn't mention this, but Traverse are kicking themselves because they didn't do any mechanistic data, and they but they did actually show that fracture risk was higher in the testosterone group. They don't know why. They haven't reported the data, and so that's a big question mark. No one knows, and they haven't done anything to explore why that may be. So, but I don't think that should change what is common sense, which is that hypogonadism causes is a risk factor for osteoporosis, and that testosterone should be something that, you know, all the data so far shows that it actually mineralizes bones.
And how long should TRT be continued? Is the question.
That's a fantastic question, and I think it should be assessed periodically if someone's on long-term maintenance. So look, if someone has an irreversible cause like hypog, then they need an annual review just to make sure their levels are fine, but they will need to be on that for life. If someone has a potentially reversible cause because of obesity, then we must not lose sight of lifestyle intervention and the need to improve their general health. And I think there should be periodic, maybe every 1 to 2 years, almost a window for 1 or 2 months, just to almost open the lid and see what their testes can do, and then if it's not, and then close the lid again. So I think there should be a reassessment where there could be scope for recovery.
Thank you. And one last question. Any evidence of cardiovascular risk in patients with normal testosterone that use it to improve libido or muscle mass? A controversial indication.
Absolutely. I'm actually glad you asked that. So we know from men who use, so we're talking about anabolic steroids, and I think whether you're in a private clinic inappropriately prescribing it, or whether you're buying it on the internet or on the black market, there is good data showing it causes cardiomyopathy, it causes thrombosis and hypertension, and so it is unsafe. So exogenous excessive testosterone is always dangerous and unsafe.
Fantastic. Thank you so much again for a really informative and clear talk.